Good afternoon. We'll call to order this afternoon's meeting on the Committee on Health and Human Services. Secretary, will you please call the roll?
Assembly members Dahlia, Edgeworth, Gonzalez, Goulding, Gray, Hafen, Hibbets, Hunt, Jackson, Koenig, Nadeem, Nguyen, Orentlicker, Chair Brown May.
And I am here. Thank you. We have a quorum. So a couple of housekeeping announcements as we begin today. I want to officially welcome our audience here in Carson City, anyone who's joining us in Las Vegas, and those who are on the telephone lines today. Please silence your electronic devices. If you wish to testify, please sign in at the table and provide our committee secretaries with a business card. When testifying, please remember to turn on your microphone. Clearly state and spell your name for the record. Electronic copies of any of your handouts should have been submitted to our committee secretaries. Members of the public may call in and provide public testimony. To do so, you would call 888-475-4499, and then when prompted, provide the meeting ID, which is 876-3267-8981, and then press the pound sign. I will repeat that number again later as we move into public comment. Public comment will be taken today at the end of our meeting, and each person will be limited to 2 minutes. Please remember, we expect courtesy and respect in all of our interactions. And note that our committee members will be using their electronic devices. It is not a sign of disrespect. They are looking up all of their electronic handouts. Okay, so we are excited to start our business for today. We have a presentation, committee members, from the Nevada Donor Network representatives. I would like to call you all forward. It's great to see you. Thank you for being here. If you would please introduce yourself, spell your name for the record, and then you may begin when you are ready.
Well, good afternoon, Chair. My name is Tyree Gray. That's Tyre Gray. I'm the Chief Administrative and Legal Officer for the Nevada Donor Network, and it is wonderful to be here in front of you today. For those of you who may not know about the Nevada Donor Network, it is one of the state's organ procurement organizations. And in organ donation, it's one of few areas where both grief and gratitude can exist at the same time. There's the grief of losing a loved one, but then there's a gratitude of the over 8 lives and 75 other lives that can be saved and or healed throughout the process. And so today we wanted to come by and chat with you just a little bit, share some of the things that we've been up to, because we were fortunate enough to be granted an ARPA grant, and we wanted to let you know how those dollars have been deployed and how we've been able to effectively really move our organization into a new tier, which is a Tier 1A status with CMS. So today I brought along with myself is we have our Chief Executive Officer and President, Joe Ferreira, and he'll introduce himself. And we also have Elizabeth Shipman, and then a little bit later on, we'll bring up Dr. Momenti. So I wanted to pass it over to Joe to speak a little bit about what we've been up to and kind of where we're going.
Thank you, Tyree. Madam Chair, members of the committee, thank you so much for having us today. We're honored to be here, and we are grateful for the opportunity to tell you what we've been up to. My name is Joseph Ferreira. I'm the president and CEO of the Nevada Donor Network. My name is spelled JOSEPHFERREIRA. And my role in today's dialogue is basically to give you some historical context about the Nevada Donor Network. As Tyree noted, we are the organ procurement and tissue recovery agency for much of the state of Nevada. We were founded in 1987, much like some of the other OPOs around the country, and we've been around that long. In 2011, we had some challenges, regulatory-wise, before any of us were involved in the organization. Fortunately, we were recruited to turn that around, and now we are a model and an example of what an organ, tissue, and eye recovery agency should be. And it's one of the few healthcare success stories here in Nevada, and we want to make sure you know that we were in a pretty dark place, but now we are a model, and many come to us to find out what we're doing differently to save and heal more lives. In terms of the ARPA dollars that we're very grateful recipients of, we were able to deploy those funds to resolve another problem that we have here in Nevada, which is access to transplantation, which is challenged at best. Having one kidney transplant center in southern Nevada that also transplants pancreata, but no other transplanting center here in the entire state. So if you need a transplant, many Nevadans like us have to go somewhere else to get that care in another state. And that was unacceptable to us. It should not happen, especially since we are a model on the donation side of the equation. So we deployed those funds to start the Nevada Transplant Institute, another nonprofit. And Elizabeth, before we get into the transplant side, is going to tell you about some of the other programs we catalyzed with the ARPA dollars that we were recipients of.
Hello, good afternoon. Thank you for having me. My name is Elizabeth Shipman. I am the Vice President of Organ Services at Nevada Donor Network. My name is spelled ELIZABETHSHIPMAN. So as Joe and Tyree have both mentioned, we were grateful recipients for the ARPA grant. And with that, we were able to really lean into utilizing innovations to expand the donor pool to honor the donor's wishes. So we onboarded some machine perfusions, and these machines are able to simulate the organ, and they're kind of able to rehabilitate the organs. So they make more organs available for transplant. Since we are a mass exporter of organs and the recipients in Nevada go to other states to get their organs, we had to find different ways to become innovative to expand that donor pool. In addition to the machine perfusion program that we started, we also received funds to enhance our clinical laboratory. So now we have a state-of-the-art histology laboratory. And then last session, we were, SB 109 was one bill that was passed. And with that, we were able to partner with the coroner's office to provide authorization. Just an update on that, year to date, we have been able, or since that passed, we have been able to honor 20 donors and save an additional 80 lives. So wanted to quantify that for you all. And then we also had another one, AB 154, which was providing education to mothers on birth tissue. Since that has passed, we had almost 2,000 birth tissue donors, so donors of placenta. And then this year we are anticipating about 3,000 donors from that program. So we were very, very grateful. And with that, I'm going to play little musical chairs and pass over to Ernesto to talk about what's happening with Nevada Transplant Institute.
Hi, my name is Ernesto Molmenti. I'm the executive vice president and director of the Nevada Transplant Institute and the executive director of the renowned Transplant Institute and a professor of surgery as well. I'm delighted to be here because many years ago, Joe Ferreira and I were in the national committee that redetermined how kidneys should be allocated. It was a very unfair system at the time. And Joe and I said we need to do something to stop Nevada from being an exporter of organs, and we need to do something to stop all the people who are dying because of access to an adequate transplant program. So to show the strength of our word and the power of our resolve, we started a new Transplant Institute, a joint effort with the Nevada Transplant Institute and the renowned Transplant Institute to provide help for all those who cannot leave the state, who don't have the funds, who don't have the means, who don't have the power to be able to leave the state and are dying while on dialysis. Based upon that, we established what will soon perform its first transplant in northern Nevada. And we're here to win. We're not here to be number 2 or number 3. We're here to be number 1 and to make Nevada the transplant capital of the United States. We're going to do kidneys, livers, hearts, lungs, and with your help, we're going to be unstoppable. Because we cannot, we must not, and we will not accept to be relegated to the last positions. We're here to be number 1, and we're here to win, all of us together, to show to the world that we are going to do something that has never been done before, so all the other centers can follow our initiative and can follow our example. That's briefly what I plan to do. We'll do it together, and we will not stop until we have achieved it. And thank you for having met with us.
So, Chair, again, as you can tell, we are up to a lot of exciting things. We didn't want to take too much time away from you, but obviously if you guys have any questions about what the Nevada Donor Network has been up to, you've heard a little bit about our plans. Obviously, we're more than happy to take those. Otherwise, we just want to thank you, Chair, and the members of the committee for giving us the opportunity to come in and speak a little bit about the Nevada Donor Network.
Thank you. We are happy to have you here today. I appreciate your comments. It's wonderful to see you and your colleagues that you've brought with you. We do have a couple of questions, and we will start with Assemblymember Gonzalez.
Thank you so much. Hello, good to see you all here. I know that there was recently a New York Times investigative piece about the waiting list, the transplant wait list. And so I was just wondering if you could maybe speak to Nevada and how we're managing that or combating that here in our state with your amazing organization. Thank you so much.
Thank you for the question. Again, my name is Joseph Ferreira, for the record. We are in a unique position here in Nevada, as you've heard from some of my colleagues, that we are mass exporters of organs until there's more robust transplantation here. And so we
will start, by the way.
and so because of that, we need to make sure we get the kidneys to where they're going to be transplanted out of state as quickly as possible, along with all the other organs. And we follow the national allocation system to be able to do that. There are some exceptions when timing is critical and the kidneys, for example, are out of the body, and we need to expedite placement to centers that will actually transplant them. But for the most part, we follow the allocation system and we make sure the kidneys get to where they're going to save somebody's life. Does that help to answer your question?
Yes, thank you. I'll follow up offline. Thank you so much.
Thank you. Next, we have Assemblymember Edgeworth.
Thank you for that presentation and for the amazing work you guys do in educating people and getting people signed up. I think it's amazing. I have a question. I heard a rumor. We probably shouldn't talk about rumors, but I heard a rumor that UMC and UNLV was going to be starting liver transplants in the near future. Do you have any, this might be in the weeds, but do you have any thoughts on how many people we send away from Nevada to get livers in other states right now?
Thank you for the question. Again, for the record, my name is Joseph Ferreira. We estimate that at least 150 to 200 people are going out of the state to get the care that they need for liver transplant. And that number we think is underrepresented. You know, when you're waiting for a liver transplant, you don't have many options for treatment to extend your life to wait for the liver. Typically, if you can't get the care you need pretty quickly, you pass away, you die. And we estimate that Nevadans are dying because they can't afford to relocate, get listed somewhere else, and the window closes on them and they get really sick and then die here. So we estimate the number to be in the hundreds. We're grateful that UNLV and UMC, if the rumor is true, are going into liver transplantation to augment their kidney program, but the number is real, and it's Nevadans who are passing away even if they can't get, especially if they can't get listed to begin with.
Yeah, let me add something. You're a physician, Dr. Edgeworth, I understand as
Would
well.
you please state your name for the record? It'll help our secretaries.
Ernesto Molmenti. We cannot be very grateful for somebody to take our patients away, to take our citizens away, to take our Nevadans away. We have to start a program here to help them and to say we are going to do it here in Nevada because we're strong and because we are able and very capable to do it. And you're going to follow our example as well.
Thank you, and I appreciate the optimism.
Absolutely.
Members, any other questions? No, I do have one.
I have a comment, sorry. Go ahead.
Thank you.
Yeah.
Thank you. This is my committee, but thank you. I do have a question. So we heard a bill earlier this session about a young lady, she was a child, lost her life, and then became an organ donor that benefited 3 or 4 other children. I'm curious to know if you have a personal story that you would be willing to share with us about what drew you to the Nevada Donor Network. My question obviously is directed at Mr. Tyree.
Yeah, no, well, again, Tyree Gray for the record. Chair, thank you so much for what you're doing. And yes, I do have a personal connection. I think there's the Hair Club for Men commercial way back in the day, right? It's like I'm not only the president, but I'm a client, right? And frankly, the Nevada Donor Network saved my life. 13 years ago, I received a kidney transplant, and the Nevada Donor Network is the organ procurement organization that helped to be able to facilitate that organ transplant for me. And so there's these unique moments in time where you have those full circle moments where you get to, again, I speak about that grief and gratitude. And there's just so much gratitude to be able to be at an organization that not only does good work in the community, but that I personally benefited from, because I wouldn't be here today but for the hard work that the employees of the Nevada Donor Network do on a day in and day out. And so it's just an honor. And thank you so much for giving me an opportunity to speak on that.
Thank you for your willingness to share your vulnerability with us and your personal story. I do appreciate that. You are welcome to make a closing comment at this time if you would like to.
I just wanted to say how great it is to work with all of you, and I look forward to an incredible partnership to achieve outstanding results. And thank you for having us here today.
Sure.
Thank you all. Thank you, Madam Chair.
Okay, members, we have 2 additional items on our agenda today. So next we will open a bill hearing for Assembly Bill 161, which makes revisions relating to hospice care, and will be presented by our Assembly Member Edgeworth. We will give you a couple of minutes to get down and get situated, and then take your time. You may begin when you are ready.
Okay, good afternoon, Chair Brown-May, Vice Chair Wen, and fellow members of the committee. I'm Dr. Rebecca Edgeworth, and it is my honor to represent Assembly District 35, which is down in Southwest Vegas. I'm also very proud to present Bill 161 today, and this bill addresses the appalling state of hospices in Nevada and seeks to improve care for people who are dying. As a physician practicing in Nevada for over 20 years, I've referred many patients to hospice. I've sitting down and having heartbreaking end-of-life conversations with people, patients and their families. It's very hard for everyone who's involved. But when I explain how hospices can hope to offer support and genuine, compassionate care, it's usually a sense of relief that people have. I've personally had my own family members who have passed while on hospice, and I can attest that when done right, hospices can be a blessing and a comfort to both patients and families. It was recently brought to my attention that there's been an influx of new hospice providers in Nevada. The growing number of providers has introduced unnecessary fraud and abuse that threatens the safety of the most vulnerable members of our community. Driven by greed, some of these new agencies are giving horrific care to people at their most defenseless and right at the end of their lives. Further, it's become apparent to me that the perfect victims of this unacceptable treatment are people who are dying and can't complain, family members who are too brokenhearted to complain, and that assumes they even know who to complain to. So when I was asked to sponsor a bill to increase awareness and make tangible changes to this problem, I could not sign on fast enough. You'll see from the testimony today and from uploaded letters that hardworking, legitimate hospices are very much in support of this bill. We'll tell you about some of the most egregious things that are happening, including people being signed up for hospice when they didn't know they were on hospice, hospices who are taking advantage of regulatory loopholes to avoid reporting requirements, and dying patients that are literally not getting the care they deserve as human beings. I know many of us have had loved ones on hospice, and when you hear the details of how these unscrupulous hospices have been operating in Nevada, please keep in mind, there are hundreds of people lying in beds dying today who have no friends or family to advocate for them. It is our duty to hold these hospices accountable. At the table with me to present AB 161 are Karen Rubel from Nathan Adelson Hospice, as well as Dan Musgrove, who will go through the bill.
Good afternoon, and thank you for the opportunity to present the bill in this important legislation. And I want to thank the committee and also thank Dr. Edgeworth for sponsoring the bill for us. As she said, my name is Karen Rubel. I'm the president and CEO at Nathan Adelson Hospice, and I've had the privilege of being with the organization since 2007. Nathan Adelson Hospice is Southern Nevada's oldest and only nonprofit hospice and has been serving the Las Vegas community for the last 46 years. In the last 3 years, we have seen an unnecessary growth, abuse, and neglect of the hospice benefit, along with a significant increase in hospices and an increase in questionable, unethical, and potentially illegal practices by hospice providers. We believe that this has been fueled by neighboring states cracking down on bad practitioners, which led to them relocating to Nevada. There have been several investigative articles, including one published by the Los Angeles Times and one by ProPublica, that outline detailed fraud and abuse cases. These articles have led to legislation in California that includes a moratorium on new hospice business licenses in California. The mission of hospice is to allow people to die a peaceful and pain-free death, and hospice care was almost exclusively a nonprofit service when it began, but for-profit firms have now taken over. Nathan Adelson Hospice was founded in Las Vegas in 1978 by Irwin Mulaski and Merv Adelson, and the founder's vision was that no one should end the journey of life alone, afraid, or in pain. And as I said, we are Southern Nevada's oldest nonprofit hospice provider. We're privileged to care for over 88,000 people since our inception. And during the 4 past decades, it's been an honor and a privilege to provide the most comprehensive hospice care to members of our community, regardless of their ability to pay. 46 years later, what is happening to hospice patients is just not right. And I believe that Nathan Adelson Hospice has a moral obligation as one of the 3rd hospice programs founded in the country at the time to bring this issue to light. Hospice is designed to enable a patient's quality of life that includes pain and symptom management so that their last days may be spent with dignity at home or in a home-like setting. And we have always promoted an environment that requires legal and ethical behavior and acting with integrity. The rapid growth in hospices can lead to fraud, unethical practices, and poor patient care. Licensure practices and weak oversight of hospice agencies have created opportunities for large-scale fraud and abuse in the Medicare and Medicaid programs. Hospice companies will stay under the audit radar by only enrolling a certain number of patients, so they are not required to report quality scores to CMS. As an example, a review in Clark County found multiple hospices at the same address without a corresponding increase in the number of patients that they provided care to, as well as specific individuals holding top management positions for multiple hospice entities at the same time, and again, so not having to report those quality scores. The California State Legislature and the California Department of Public Health have taken steps to curtail this disturbing growth in hospice providers. In January of 2022, California put a moratorium on new hospice business licenses in place. And with this moratorium, we saw a flood of bad actors move into neighboring states such as Arizona, Texas, and Nevada. We have witnessed questionable, unethical, and potentially illegal practices firsthand and have documented those specific cases. The impact on patients and their families is truly heartbreaking. And no one who calls themselves a healthcare provider should ever do what has been done with some patients in our community. And it's our opinion that this mistreatment of seniors is taking place when they are at their most vulnerable. So you'll see there on slide 1 that we've been tracking new hospice business licenses that have been issued, and this is from the Secretary of State's website. And so you can see from 2022 through 2025 the increase in hospice providers. And this is really in Clark County, not throughout the entire state. So you can see that over 271 hospices have business licenses right now. Slide 2 talks about the transfers of hospice patients to Nathan Adelson Hospice. When I started in hospice in 2007 at Nathan Adelson, it was very rare that a patient would transfer from one hospice to another. There's a whole host of reasons that might happen, but it was very rare. You might have 1 or 2 patients transferring a year. Since we've seen this influx of new hospice providers, you can see since 2022, we had 21 patients transferring. So we started to talk to our family members about why they're calling to transfer to us. And then it's just gone up from there. So in 23, there were 57 transfers. In 24, 75. And right now, in the beginning of the new year, we've already seen 16 people transfer from another hospice. And so we began tracking those reasons and why are people calling Nathan Adelson Hospice. And so we wanted to share a couple of examples. So a patient calling, wanting to transfer from Hospice A to Nathan Adelson Hospice, the family was upset that the patient had an open wound from a biopsy site that became infected and painful. The patient's friend and daughter both verbalized this concern to the hospice provider. They state that the hospice told them that their mother could go to their inpatient unit for 5 days, but would incur charges after that. And we're not sure what their unit they're talking about, but both asked if the RN at Nathan Adelson, if they would be kicked out of hospice if they stayed too long. In the second example, a caregiver wanted to transfer to Nathan Adelson Hospice due to overall dissatisfaction with the care they were being provided. Their loved one had been on hospice since he had been discharged from the hospital, and he had an episode where he was in excruciating pain based on the placement of a Foley catheter. They called hospice, the hospice that they were enrolled in, asked for them to send a nurse out. The hospice kept saying no, they were going to send someone in the morning. They ended up calling 3 or 4 times, and finally the hospice did send a nurse out, but their loved one was in such terrible pain, they just didn't know what to do, and so they wanted to transfer to Nathan Adelson. In the third example, the sister had called because the previous hospice didn't have any staff available to send out to take care of the patient. The patient was bleeding. They called the hospital. They were told to call 911 and take him to the emergency room. The patient had open wounds on their lower extremities and GI bleeding, and so they revoked services to come to Nathan Adelson. The next example is that the patient arrived at the hospice but was discharged when he was found to have a temperature of 100 degrees. He was sent to the hospital. The patient was on hospice services in a house that was unlivable with feces and rats present all over. The patient presented again to the ER for weakness and altered mental status, and they ended up calling Nathan Adelson Hospice to provide a better space for this patient to live in. And then our final example was that patients don't realize that they were signed up for hospice. And so they're getting hospice care. That hospital is billing Medicare for that care, but the patient and the families don't realize that their loved one was on hospice care. In this particular situation, the patient needed a specific level of care, which we call general inpatient care, which all hospices are required to provide based on the conditions of participation for Medicare, but we're finding that many, many hospices don't provide all 4 levels of care, and so they hold on to that patient until the very end, and then they transfer that patient to Nathan Adelson Hospice. We'll never turn those patients away, but that hospice has a responsibility as a Medicare provider to provide that level of care. And we have many, many more examples of patients receiving substandard care and operators not adhering to the CMS conditions of participation. CMS makes it very clear that patients have a right to choose hospices, and this is not about competition. I believe that competition keeps us on our toes. We invite competition. We've had competition in hospice in Nevada for as long as I can remember. And it allows us to not take ourselves for granted. But we are currently seeing in the current environment is that these hospice providers cannot even deliver the basic level of hospice care for patients, and these are elderly patients, let alone provide all 3 levels of care that are required. And so while it may seem daunting, we must fix hospice care. Existing policies should be strengthened and enforced. Policies related to the protection of our seniors and those most vulnerable should be enacted, and new policies to close loopholes that corrupt agencies that can exploit should be developed. Caring for people who are dying has become a big business, and we should not let greed dictate care that vulnerable patients receive. And we urge Nevada legislatures to support this critical legislation for hospice in Nevada to protect patients and seniors. Thank you.
Thank you, Madam Chair. Dan Musgrove with Strategies 360, representing Nathan Allison Hospice. And I want to make sure that you understand that the bill before you today, AB 161, is a work in progress. We've had a lot of folks that have contacted us with ideas and issues with the bill, and we are more than happy to work with them on this. And as well, we realize that there's a potential large fiscal note with the way the bill is currently written in this session. That is not a good idea to have a fiscal note, and we certainly believe that we would like to obviously get something out of this bill that begins the first kind of steps of protecting our constituents, your constituents, all of our constituents, and Nevadans who are being taken advantage of. And so I'm going to really kind of skip through the bill really, really fast because I really just want to call your attention to probably the most important part. Granted, Section 2 talks about an interdisciplinary team, and we realize that that's very important for each hospice to have. Section 3 talks about licensure and when they need to actually become accredited by CMS for Medicare. Section 4 is one of those fiscal note chapters, sections, and so we'll be looking at probably deleting most of that chapter. Section 6 is similar in that regard in terms of what it asks our state regulators to do. It does put a burden on them, and it would cause a tremendous fiscal note. And again, we think that there's a way around this that would at least, again, put something in place that we can be proud of to, again, start protecting health. And in my conversations with Administrator Cody Finney and her team, we think that there are some ways that we can get this bill into a position where it would have a minimal fiscal note. And that certainly is very important to us because we want to give you guys a chance to know that we'll get to the other side and get passed by the governor. So moving on to Section 8, and again, not much changes. Section 11, again, is one that's probably allows for the adopting of the regulations that we'll put in place. And but truly the most important part that, and I do want to say that there is a there's a section in the bill that talks about sections. It's on page 11, starts at number 14, line 19, in terms of passing regulations that will aggregate and the annual maximum of payments. We think that's probably unworkable. We certainly don't want to restrict our good operators from doing the work that they need to do, and that could eventually bring everybody into this ability where somehow it seems that they're taking advantage of Medicare when we know that they're not. They're just providing care to folks who need it. And so I do want to skip down to Section 14. We feel that probably 5 years for the administrator is a little bit much. We want to narrow that down to 2 years for an administrator, as well as the physician a medical director, in terms of the experience that they have. But again, the most important part of this bill, we would call your attention on page 15, would be beginning at lines 15 and going down to lines 38. These are those provisions of care that must be delivered by a hospice company. These are the things that they should expect to get, that their family members, their loved ones should mandate and demand that they get. Routine care in the home, general inpatient care for the management of pain. I mean, you think that these are things that are so obvious, but again, we're not seeing it happen because they don't have the resources, nor do they plan on having the resources to add these things or even provide these. Continuous home care for the acute management of symptoms, care for the patient, which provides respite from the stresses and responsibilities that result from the daily care of the patient, designates that disciplinary team to meet with the patient. And it was also pointed out from someone I think you may hear from later today. We need to make sure that the person in the interdisciplinary team that visits the patient is probably maybe a nurse or physician and not just maybe a social worker, because again, we want to make sure that they understand what's happening with the patient. So we're working on changing that as well. And then provides for the visitation of the patient by members of the interdisciplinary team. They should have a physician on call 24 hours, 7 days a week, in which they can respond to the needs of these patients. And again, has entered into contracts with facilities so that if they do need a higher level of care, that there is an ability to transfer, not just because the patient has no other place to go do they look for a transfer, that's a part of the level of care that this provider works with and has agreements with other places where they can have this help. We're willing to waive probably the 40 hours of a training for the doctors. We do believe that they need experience and training and knowledge in hospice because it is a very unique science of care for patients. And so we're willing to work with probably NMSA to talk about what it is that they should have. That maybe they can demonstrate a level of experience that we know that can equate to the 40 hours of care, that the training. And the thing that's really concerning is that on the last page 19, and I'm not sure why this was put in, but it talks about, it's basically a grandfather clause that would allow anybody that's licensed as of January 1, 2026 to not have to adhere to any of these provisions. So we certainly want that to go away. And with that, we would allow any questions. And we do have a couple folks online, one from the national perspective that can talk about what's trying to be done at the CMS level, as well as another provider. And again, thank you for your attention today.
Thank you. I appreciate that. Are they part of the original presentation? We do have a number of questions. Members are waiting. And so
Let's go ahead and take those questions.
are you good? I mean, we have folks here nationally. You said they dialed in. Are they part of your presentation? Can we expedite that and go quickly there? Okay, I believe we have Miss Lund who is ready and prepared.
I'm ready.
There you go.
My name is Judy Lund Person, Judi, Lund, Lund, and Person, Person. I am a senior advisor for the National Partnership for Healthcare and Hospice Innovation, located here in the DC metropolitan area. Thank you so much for allowing me to be with you today and to talk a little bit about what we know about hospice care and hospice fraud and abuse in all parts of the country, including California, Nevada, Arizona, and Texas. And I also want to share an additional story from to what Karen has shared about a patient who was a California patient who was admitted to hospice, nursing home resident with dementia in her 90s, and her daughter was her power of attorney. She was fine. She was not terminally ill. She went to the doctor to get her pacemaker battery changed. And as a result of going to the doctor, she found out she had been enrolled in hospice. At that point, then the daughter started the long haul of trying to convince CMS, trying to convince Medicare that no one had agreed for her mom to be on hospice, and what could the hospice do, and what could CMS do. She was on hospice from November 14th to March 12th, and she never one time saw any hospice professional. The nursing home where the mom resided had no idea that the patient was on hospice. She could not get PT. She could not get her pacemaker changed. She could not get any medical services. That's part of the rules with the Medicare hospice benefit is when you choose hospice, the other medical services for your disease are really all done by the hospice. I myself got very involved with the case in January of last year, and we talked to the Center for Program Integrity. We talked to 1-800-Medicare. We talked to the Senior Medicare Patrol. We talked to the folks who are in charge of hospice payments. We talked to folks who are in charge of the hospice survey process. Not one of them could figure out how to get Sabine, her first name, and I'm allowed to use that much, off of the Medicare benefit. So I share that story because this is a really passionate issue for all of us, and we want to make sure that Medicare beneficiaries have the right, have the access, and have the quality of care that they deserve at the end of life. Thank you so much for my being able to be here today.
Chair, we'll stop our presentation at that point. There is a Ms. Torres, but we'll just allow her to speak up in support, and it will be open for questions now to move things along. We appreciate your willingness to allow us to testify.
Thank you. We appreciate that. I had Ms. Torres identified as a support, so we'll go to her at that point. So thank you. We appreciate that. Okay, we do have a number of questions from our members. We'll start with Assemblymember Gonzalez.
Thank you so much, and thank you so much for the presentation. It's really concerning hearing that some of these facilities are not having some of these standards, so I definitely empathize with that concern for our most vulnerable community. I was wondering if you could talk about kind of, Vegas is one of the fastest growing valleys, right? And we're talking about that we're currently oversaturated with hospice care. So I was wondering kind of, what is the thought process behind that, if there is a thought process behind that, and or how do we ensure that we have regulated facilities that are meeting the needs of the growing population? Thank you.
Karen Rubel for the record. We are seeing an explosion of the community in hospice, and we have one of the largest centers of senior populations in the country. So I think that's what is leading a lot of these bad actors to come to Southern Nevada, because we do have that concentration of seniors and Medicare recipients. I think that legislation like this needs to be enacted so that we can keep those bad players out, and that we can hold people accountable as they're performing hospice, not only from the Medicare, so Medicare has their own set of rules, but on the ground in the state when someone wants to set up a hospice, that we need that extra hospice. I don't think we need 270 plus hospices just for Clark County. I know there are some additional hospices here in the northern part of the state, but that concentration, I think, is being led by the fact that we have so many seniors in that area.
Next, we have Assemblymember Gray.
Thank you, Madam Chair. Thank you, Dr. Edwards, for bringing this. I see the problem, but I think it also points to another problem. What agency is tasked with overseeing and inspecting and making sure these people are doing the job they're supposed to be doing for these folks?
Dan Musgrove. Thank you, Assemblyman Gray. I think that, again, it's the Department of Public and Behavioral Health, specifically HCQC, Healthcare Quality and Compliance. And as was testified earlier, because of their responsibility, usually they're complaint driven. They do have CMS does have a responsibility to certify that these folks are good, that they follow laws. HCQC acts as the agent, although we have learned that there has been inspector generals brought to Nevada by CMS to do some inspections. The trouble is we just haven't seen any action at this point. And as Karen testified to before, we turn in every complaint that we get, and the HCQC does do a great job of investigating those specific complaints, but it's hard to get folks to complain about something they're not aware of that they've been taken advantage of. And that's why we really, of anything out of this bill, we want it to be a patient's bill of rights so they understand what they should get and should demand. And therefore, they know what to complain about. And that's very candidly, I think, what's been the problem, is that people just don't realize they're being taken advantage of.
Thank you, Mr. Musgrove. Madam Chair, can I have a follow-on, please? So I've dealt with other licensed agencies and stuff that, throughout the state, not necessarily in medical care, but, you do have for like hospitals, I forget what it's called now, it used to be JACO. There's other inspections for like funeral homes and stuff like that where they pay the board their fees, and then every few years you'll have just an inspector pop up at your door. So you're saying there's nothing in the state like that to pop in and check on these folks and check their quality care on a random basis or anything like that?
Yeah, I can take that one. Karen Rubel. Yes, so there are accrediting organizations that will accredit a hospice to start receiving Medicare payments. So that's one requirement from Medicare. So they get their accreditation to open their doors and start taking their first patient that they're going to send a bill for. But then after that, there's not a regular type of an audit or a visit by that same accrediting organization unless you're over a certain size of hospice. And so a lot of these bad actors can fly under that radar because they get their one accreditation and then nobody comes back and does any kind of follow-up.
Thank you, ma'am. I find that very disturbing. Thank you, Madam Chair.
Thank you. Next, Vice Chair Nguyen.
Thank you, Chair, and thank you for bringing this forward. As you were talking, I was kind of went down memory lane for a second and remember, when the Asian community learned about what palliative care is, and we did a study on that, and it was overwhelming for many of the Asian community members. Have no idea what that word even means, right? So coming over to this hospice care conversation, are there thoughts about, and you mentioned this in page 15 earlier when Mr. Musgrove mentioned the types of care that are standard of care, and then over on page 16, section 14 for the training component, are there thoughts about adding the language access piece? Because if you're already experiencing people don't even understand that they got signed up to hospice, if we add that layer of language barriers, then there's going to be a lot more, many more complaint, because I can see that, in their time of needs and or in their time of crisis, language barrier will create additional layers of more folks being victimized by this. So whether it's going to be from a training perspective to providers or even on a regulatory compliance perspective, hopefully y'all could consider adding that in.
Dan Musgrove, absolutely.
Thank you. Assemblymember Ornlichter.
Thank you, Chair, and thank you for bringing the bill. On section 15, if we could go to that, would you lay out the kinds of care that need to be provided? And I'm looking on page, let's see, well, 15, section 15, starting in lines 15, which lists the kinds of care that each hospice must provide. Routine care in the home, general inpatient care. So it kind of suggests that you couldn't have a hospice that only does home hospice care. And maybe that's good, but we do have agencies that provide home care in other kinds of health care, and that's all they do is home health care. But does that not work for hospice, that it's important? And I can see why you would want to go with the patient when they're admitted to the hospital, to continuity of care. Is that, if you could just elaborate on that?
Sure. Karen Rubel. So CMS requires that a hospice doing business has to provide these 4 levels of care. So the very basic first level of care is at home. So a hospice should go to your home or wherever it is that you call home. And then depending on the the diagnosis of the patient and kind of their trajectory and their journey, there's a respite level of care that's offered. So if there's caregiver burnout, the hospice must provide a respite level of care. There's continuous care that happens in the home. If symptoms start to become unmanageable, then there's a little bit more touch points by the nurse and the certified nursing assistant in the home. And then there's general inpatient care, which that patient comes to an inpatient unit or a facility to receive that level of care, and that's 24-hour level of care, and that's for a short period of time. The goal is from that inpatient level of care to get you back to where you call home. So these are just general levels of care that are required if you are accredited by and being paid by Medicare and billing Medicare, but what we're finding is that these 4 levels of care are not being offered to all patients.
Thank you. Next, we have Assemblymember Nadeem.
Thank you, Madam Chair, and thank you for the presentation. So my question is that the hospice facilities, they are overcrowded, or there's lack of care for the patients. Do you think the lack of the shortage of workforce, the nurses and the doctors and the people who are expert in this, there's a shortage, and that's why we are also seeing that lack of care?
Karen Rubel. What I would say is that it certainly could be. So there is a workforce shortage in healthcare with nurses and certified nursing assistants and really even physicians. But at the rate of the growth of the new hospice programs coming into the community, that's just pushing on that shortage, right? So if there weren't over 271 hospices that were looking to hire nurses and doctors and certified nursing assistants and social workers, you wouldn't have hospices that didn't have those employees to send out to patients' homes. So I think it's a little bit of that. And also, hospice is reimbursed on a per diem rate, so you get a certain amount of money per day for the care of that patient. And that's up to the hospice to disperse that however they want to. So they can put that money back into the bedside. They can put that money into making a margin on their business, however you want to use that per diem rate. So a lot of that kind of makes for this perfect storm of, just really, really bad care for the patient. But I think that, there certainly is a workforce shortage in healthcare, but the fact that we see so many hospices just in one concentrated area just adds to that problem.
Can I have a follow-up, Chair? Thank you. Thank you, Chair. So do you think that we need more hospice because of the population is increasing in Nevada? It's the rate is increasing so fast.
Karen Rubel. I don't think we need more hospices because the percentage of people that access hospice is not increasing year over year. Right, and so in coming out of COVID, that people accessing hospice actually decreased of eligible hospice members in the community or Medicare recipients. So I don't think that we need more hospices because hospice happens at home. So you just need the staff to go to that patient's home. So it's not a place that people come to for care. We're going to the patient's home. So it's not that they're overcrowded or hospices are overcrowded. Again, I think it's the workforce issue. They're trying to find that workforce. But all of the care is designed to happen at home.
Okay, thank you.
Rebecca Edgeworth, for the record. There is, between 2020 and 2025, there's been an over 400% increase in number of hospices, and that is not in line with I agree that there is a population increase, but certainly not 400% during COVID since 2020.
Thank you. Next question, Assemblymember Jackson.
Thank you, Chair, and thank you, Dr. Edwards, for your work and advocacy for the most vulnerable populations, even on your birthday. My question is, for Medicaid services that are requesting hospice care, is there prior authorization for these services? And if there is prior authorization for hospice, what does that look like with Medicaid?
Karen Rubel. Yes, there is prior authorization for Medicaid. Usually the prior authorization, there is no issue with that. If the patient needs to be placed somewhere, we work with that patient to find a facility that will take a Medicaid patient and Medicaid payment. So for the Medicaid population, there really is no difference in the quality of care that they're getting. But lots of hospices won't take a Medicaid patient because of, you don't get reimbursed at the same rate you do for a Medicare patient. That your payment sometimes is slowed down depending on, the billing cycle and those types of things. But for care at the bedside, there should be no difference between a Medicare and a Medicaid patient.
Thank you. Members, any other questions? Okay, thank you very much for your presentation on your birthday. We appreciate having you here. If you will step back, we will go ahead and open up testimony in support of Assembly Bill 161. Anyone here in support of Assembly Bill 161, please come forward and fill in the chairs. You'll have 2 minutes. Please state and spell your name for the record. You may begin when you are ready.
Madam Chair, members of the committee, Sasha Sutcliffe-Stevenson for the record, SASHA-SUTCLIFFE-STEPHENSON. I'm here on behalf of the Nevada Oncology Society, and we are in support of this bill.
Good afternoon. My name is Diego Trujillo. I am the CEO of an organization called Las Vegas Heals. In addition to that, I actually began my career in healthcare as a hospice chaplain and worked for 7 years discharging and working with families. Due to my long experience, I founded a group called Vegas Healthcare, which has about 18,000 healthcare workers. I often start receiving calls from the community, especially within the last 2 years, making comments, hey, somebody came into our independent living and they signed up about 6 patients onto hospice. Lasted about 6 months, and then they signed them all off. Is that a little weird? I've been hearing these reports more and more, so I just wanted to come and throw our full support behind this bill. I think that many patients, and I was working with the families discharging them, many patients would often not be alert and oriented to exactly what was happening. They would be misled, and things weren't presented. Having a Bill of Rights or offering them what hospice services is and letting them know that they are on those services are essential for our state, especially as we're seeing this growth. So I'm very grateful. Thank you.
Thank you, Chair and members of the committee. Excuse me. Blaine Osborne, President of Nevada Rural Hospital Partners for the record. Happy to be here in support of this bill, especially with some fine tuning that is still to come. Initially, we had some concerns with talk of moratoriums and caps on the number of hospice providers and what that would do in rural Nevada. So appreciate that the proponents have brought this bill in a way that we think injects some accountability in such a way that doesn't negatively impact rural Nevada. Thank you.
Hello, my name is Steve Phillips, STEVEPHILLIPS. I've been in Nevada since 1992. I was the first fellowship-trained, board-certified geriatrician in the state of Nevada, and have had the privilege in the past to address HHS on several occasions. I just want to make a few observations kind of over the 30-plus course I've had in Nevada.
If I could interrupt you, are you here in support of this
bill?
bill?
I am in support of 161.
Thank you.
Sorry. Yeah, I was supposed to start with that. Yes, I'm in support of 161. And I also have served over 25 years on the National Committee for Quality Assurance on the board, which sets all of the quality care measures for Medicare and Medicaid. It's what leads to the star ratings, et cetera, for Medicare plans, accountable care organizations, and for Medicaid programs. So I have quite a bit of knowledge in the space of quality of care, whether it's in end of life, prevention, whatever. Since 1995, I have founded 5 hospice agencies in Northern Nevada. As medical director, no financial interest in any of the 5. I have handed them off, and they're still actively working in Northern Nevada, and like to say probably some of the best in Northern Nevada, from my opinion. And I currently serve part-time as medical director for Prominence Health Plan, the Medicare Advantage Plan, And I'm able to interact with 3 hospices that I had founded and remain very pleased with the work they do. So in closing, I do want to lend my support to Assembly Bill 161. I also have 5 areas. 3 were already captured by Mr. Musgrave, for possible amendments. I have.
Thank you, sir. If you will begin to wrap your comments, you're over 2.
I don't see a timer. See, it's not running.
No, it's over here on my phone. It's on my desk.
Well, I'm used to. Okay, never mind. I will give I've already handed Dr. Edgeworth these 5 suggested amendments, and I appreciate your time.
Thank you so much. You may begin. Go ahead.
Good afternoon, Madam Chair and members of the committee. Melissa Clement, MELISSACLEMENT of Nevada Right to Life, testifying in support of AB 161. We thank the bill sponsor for her work to bring this very important measure. End-of-life issues are exceptionally hard, and we as humans do what we can to avoid thinking about it until that time comes. And it's just, obviously too hard and emotional to think about these things. So patients and families find themselves at this point without the experience or the knowledge to know what hospice is, what the questions to ask, and where to turn. Hospice, when done right, is such a gift to both the patient and the family, providing pain management, counseling, spiritual cares, and also answers. Hospice nurses often become a partner and a member of the family, and that's why accountability is so important. Families don't know what they don't know. Thank you again to the bill sponsor and those working on this bill. I'm looking forward to seeing the amendments, and thank you so much for your time.
Thank you. At this time, we'll go to Ms. Torres, who is joining us on Zoom, I believe. You may begin when you're ready.
Hi, my name is Becky Torres, and I'm in support of 161. I am the owner of Bright Star Care, a personal care home health care company that has served our community for 13 years. We provide private pay home health services, and while we are not in competition with hospice providers, we work closely with families during some of life's most vulnerable moments. Over the years, I have witnessed a dramatic increase in the number of hospice agencies. While hospice care is meant to provide comfort and dignity at the end of life, I have seen too many companies open in recent years that lack the staffing and resources to fulfill this mission. I have received countless calls from families who, in their time of greatest need, find themselves without the care and support they were promised. Death does not discriminate. It is something we will all face, regardless of race, background, or financial status. Hospice is meant to level the playing field, ensuring that everyone can receive compassionate, high-quality end-of-life care. But without proper oversight, too many hospice providers are failing patients and their families when they need the care the most. We owe it to our community to ensure that hospice care meets a standard of excellence. I urge this body to support stronger regulations to ensure that any company providing hospice services has the ability, staff, and resources to deliver the care they promise. No family should be left without support in their most difficult moments, and no person should face the end of life without the dignity and grace they deserve.
Thank you, Ms. Torres. We appreciate you being here today. Again, anyone here in support of Assembly Bill 161, please come forward in Carson City. I see that we have someone at the desk in Las Vegas. If you're here in support in Las Vegas, you may begin.
Hello, my name is Kim Anderson Mackey, ANDERSON-MACKEY. And I'm here representing Amore Hospice Care and Amore Kids, both as the administrator and the owner. I am in support of this bill, and I also represent the Nevada Department of Health and Human Resources Palliative Care and Quality of Life Council, Advisory Council rather, that was put in place in 2017. They also are in support of this bill. So thank you again, Dr. Edgeworth and the committee for hearing this today. There have been many proposed revisions that have been shared, so I won't focus on those, but we do have 2 items that have not been mentioned. They are page 13, item number 13, which does discuss the fact of no one having the ability to determine whether a patient is hospice appropriate to have any financial gain. The only person that can determine if someone is hospice appropriate is the physician. And most of the time, again, our medical directors are paid. So we do need to revise that section as well. And then again, on our council side, we've discussed over and over the fact that there is a need for a transparent and non-biased consumer, patient, and family resource. We're proposing that this is housed, again, on a non-biased site, such as our state, and that is required for this resource, such as the Bill of Rights and other things that are named in this bill to be, this is what you should expect from hospice, to be a requirement handed out to every patient that is going on hospice and is electing that benefit. So we're looking again for that transparent, non-biased consumer, patient, and family resource to be developed. So again, thank you for your time, and we are in support of this bill.
Thank you. I appreciate your comments. Given that you're recommending revisions to the bill, we would move your comments into opposition at this point because you're not in support of the bill the way that it's been presented. Is that correct?
Correct.
Thank you for that clarification. Okay. Is there anyone else here in support of Assembly Bill 161? Anyone else in Las Vegas? AVH, is there anyone on the telephone line here in support of Assembly Bill 161?
If you would like to testify in support of Assembly Bill 161, please press star 9 now to take your place in the queue. Caller with the last 3 digits, please press star 6 to unmute your phone. You may begin.
Good afternoon, Chair Brown-May, Vice Chair Nguyen, and members of the Assembly Health and Human Services Committee. My name is Sarah Watkins, and I represent the Nevada State Medical Association, the oldest and largest organization representing physicians in our state. First, we appreciate the amendments being brought forth on the bill, and this may believe that our patients in hospice deserve the highest quality of care, that families of these patients deserve full transparency and confidence in the facilities taking care of their loved ones. Therefore, we are in support of AB 161 today. Thank you.
There are no other callers to testify in support at this time.
Thank you, AVH. At this time, we'll move into opposition. Is there anyone here in Carson City in opposition of Assembly Bill 161? Please come forward to the tables. Seeing no movement here. Anyone in Las Vegas in opposition to Assembly Bill 161, please come forward. I see no movement there. AVH, is there anyone on the telephone lines in opposition of Assembly Bill 161?
There are no callers at this time.
Thank you. At this time, we'll move into neutral testimony on Assembly Bill 161. Is there anyone here wishing to offer neutral testimony? Seeing no movement in Carson City, no movement in Las Vegas. AVH, is there anyone on the telephone lines wishing to offer neutral testimony?
There are no callers on the line.
Thank you. At this time, we'll call the bill sponsor back up for closing comments.
Rebecca Edgeworth for the record. I'll keep it very short. Thank you. Sitting here with my favorite committee, which is true. In case you didn't hear, it actually is my birthday. And I actually have no recollection of what I did on my last birthday or the birthday before that or the birthday before that. But I will always remember this legislation happening on my birthday. And I'll sleep better at night knowing that Nevadans are going to get the care that they're supposed to get. Thank you. Thank you so much to the chair. Thank you so much to the committee. Please support this really important legislation. Thank you.
Thank you. With that, we will close the bill hearing for Assembly Bill 161. And we will welcome our member back to her desk. Our next order of business, we will open the bill hearing for Assembly Bill 282, which revises provisions relating to billing for health care, and we will welcome Assembly Member Orrin Licker and his team. Please take your time, get situated, and you may begin when you are ready.
Thank you. We'll be ready. Good afternoon. I'm Assemblymember David Orentlicker, representing District 20 on the southeast side of Las Vegas. Thank you for the opportunity to present Assembly Bill 282, which would ensure that patients receive refunds when they overpay their doctors, hospitals, or other healthcare providers. So this bill does apply across the board. Unfortunately, some, and I emphasize some because this bill is not addressed at every healthcare facility or provider. Some do the right thing, but not all do. And they don't issue refunds when they realize they've overcharged their patients. This problem was brought to my attention by the Assembly member who preceded me in Assembly District 20, Ellen Spiegel. Ellen is here today to share the challenges she faced when she overpaid for health care. Now, patients may be overcharged for a number of reasons, and an important one results from the fact that health care billing can be very complicated. And an important source of complexity comes from the different ways in which insurance plans require patients to share in paying for the cost of their care. For example, healthcare insurance typically comes with a deductible. Maybe it's $500 for the year, maybe it's $2,000. Until you pay down your deductible, as a patient, you're responsible for the full cost of your care. Then once insurance kicks in, patients still may have to pay a portion of the cost of care. Maybe it's a flat fee of $25 or $50, or maybe it's 20% of the cost of care, and maybe that 20% is for in-network care if the provider has a contract with your health care plan, and if you go out of network, you might have to pay 40% of the cost of care. Well, with all this complexity, you probably should be a CPA to know what you're doing, but it's not obvious how much a patient will have to pay toward the cost of care when they see their doctors or go to the hospital. If it's January and patients still have their deductible to work down, they'll pay more than they will in December after they've exhausted their deductible. So as a result of all this complexity, doctors or hospitals might inadvertently, and I mean that seriously, a lot of this is inadvertently. They might inadvertently overcharge a patient. So here's an oversimplified example to illustrate how a patient might be accidentally overcharged. So we're the end of April, say, patients paid $1,500 toward their $2,000 deductible. So they still have $500 left. The patient sees Dr. 1 on May 3rd, Dr. 2 on May 5th. The doctors check with the insurer, because patients have different plans. The insurer reports to the doctors that the patient has $500 remaining on the deductible and that allowable charges equal $500. So both doctors bill the patient for $500, and they're doing it on information that they reasonably believe is accurate. But Dr. 2's $500 is due from the insurer because the patient will pay off the deductible with Dr. 1. But the insurer doesn't know that yet, nor does Dr. 2. So when Dr. 2 receives $500 from the patient's insurer a month or two later and realizes the double payment, this bill requires refund of that $500 to the patient because now the doctor's been double paid. Now, as I mentioned, unfortunately, not all doctors issue the refund. That's why we're here with Assembly Bill 282. And Ellen will now discuss her experience with overcharging and the obstacles to getting her payment refunded.
As you begin, former Assemblymember Spiegel, we would like to officially welcome you back to the People's House. Thank you.
Thank you so much. Thank you, Assemblyman Orentlicker, and thank you, Madam Chair and Mr. Vice Chair, members of this committee, and thank you for the warm welcome. I love this committee. I was actually Vice Chair of this committee in 2013, so my heart is in this room. My name is Ellen Spiegel, E-L-L-E-N, S-P-I-E-G-E-L, and I approached Assemblyman Orentlicker about this bill after recovering from a serious medical issue. In 2023, my husband Bill and I changed our insurance to a high deductible plan with an HSA, which meant that for the first time, it was really important for me to keep careful track of my medical expenses. By the time I got to April 2023, I had paid nearly $10,000 out of pocket, which was obviously grossly wrong because I had a $7,000 out of pocket maximum. At first, I thought the issue was with my insurance company, but it turned out that I had a misconception about how accumulators worked. At the same time, I was trying to get my insurance company to understand that I had spent way more out of pocket than I was supposed to. I went back to my providers to try to get overpayments refunded to me. I was having a very difficult time getting refunds sent to me because there is nothing in Nevada law that requires them to do so. I did everything I could, from sending letters and emails to making countless phone calls. I reached out to personal contacts asking for help. Once, while leaving a Las Vegas Aces game and walking through the casino to the parking garage, I saw someone I knew who was very senior in the administration of one of my providers who still owed me a lot of money, and I went over to him and explained my medical situation and asked if he could help me get my refund. It was at that level of groveling and needing to reach out to everyone and anybody who would listen to me at all. I'm going to use some actual dates and dollar amounts that relates to this provider so you can see that the impact that this bill can make in the lives of Nevadans. On March 29th, 2023, I paid this provider $1,457.75 as a deposit for treatment scheduled for April 5th. At the time, I was told that my EOB would be finalized in May and that if I was owed a refund, I would receive it within 30 days of my treatment. On May 9th, the EOB was processed and my cost share was $255.36, which meant that I had overpaid $1,202.39. But I never got that refund or any written communication from the provider. When I called, all I was told was that the EOB was being disputed and that I should be patient. The EOB was ultimately finalized on July 18th, and my final cost share was $181.06, which meant the provider owed me $12,076.69. So when did I finally receive my refund, and what did it take? I didn't receive my refund until November 16th, 232 days after I paid the deposit. If AB 282 were the law, I would have had my refund by no later than August 17th, which is 30 days after the EOB was finalized. I also would have received written communications each month giving me an update and telling me why I was not getting the refund they had told me I could expect by May 5th. At the time, I kept saying to my husband, Bill, thank goodness we could afford to pay this deposit. Could you imagine if we had to finance this using credit cards or payday loans like so many Nevadans do? According to the Federal Reserve, in 2023, 37% of U.S. adults would struggle to cover a $400 emergency expense, and Nevada has one of the highest concentrations of payday loan storefronts in the country, so Nevadans using credit cards or payday loans to finance unexpected medical expenses is probably not unusual. Let's take a minute to look at how much it would have cost someone had they needed to finance this from a payday loan. Check City posts their rates online, so I used their website as the basis for this. The cost of a loan is $8.25 per $100 borrowed per week. They would have needed 15 increments of $100 to cover the deposit. This would cost $123.75 per week. If they needed to finance this from the day the deposit was paid until they received the refund, it would have cost them $4,101.43. While AB 282 would not save them that entire amount, it would have saved finance charges for 13 weeks, which would have totaled $1,608.75. If you're like so many Nevadans who routinely turn to payday loans for emergency expenses, this is what you'd be looking at. Yes, AB 282 would have saved someone in this situation over $1,600. I mentioned earlier that my insurance company helped me get most of the rest of my overpayments refunded. Sierra Health and Life has a rock star employee who looked at my EOBs and contacted providers to determine what I had paid them. When appropriate, she requested a refund for me. She was able to do this because I only used in-network providers and they all had contracts with the insurer. Additionally, she also discovered that a provider took a payment from the insurer and not only didn't credit my account with that payment, they charged me for it, resulting in a double payment of nearly $1,000. I had been trying for months to get that provider to reconcile their records with mine, and they refused to send me a coherent statement showing how they applied my prepayment to my account. While they sent me their internal ledger, it was nearly incomprehensible. The staff member of the insurer was able to make sense of it, and more importantly, the billing office listened to her when they would not listen to me. The same staff member also helped with another in-network provider who wanted to charge me $307.25 for a covered procedure, despite my having reached my annual out-of-pocket maximum. Put differently, whereas providers billed or wanted to bill me significantly above my out-of-pocket maximum, my insurer helped make sure that I wasn't being taken advantage of. As you know, when someone goes through a significant health issue, it's stressful on many levels. Knowing that you've overpaid your out-of-pocket maximum by thousands of dollars and not having the providers listen to you or communicate with you in writing just adds to the stress. Thanks to this Sierra Health and Life staff member, I recovered my overpayments and was finally able to focus on other things. But it shouldn't have taken my insurance company's intervention, just like it shouldn't have taken my approaching personal contacts to get money back that was owed to me. There needs to be something in law that tells medical providers that they have to refund overpayments. I just didn't have issues in 2023, although this was probably the most dramatic. In 2024, one of my physicians closed his practice, giving no notice whatsoever, and I had been a patient of his for over 20 years. At the time he closed the practice, the patient portal said, "I have a credit balance of over $200. Despite making phone calls and sending messages through the portal, no one ever responded to me. Why? Because there's nothing in law that says that they must respond to me or refund overpayments. There isn't even anyone that I can go to for help. I'm just out that money, as are any of the other patients who were in the same situation. In speaking with others about this experience, nearly everyone could tell me about a time when they too had overpaid a medical provider and didn't receive a refund, or received a refund out of the blue, usually with no explanation and months or years after the date of service. In other cases, they didn't learn they previously overpaid until they returned to the provider and were told that there was a credit on the account which could be used for that day's copay. If you think about your own personal experiences and those of your close families and friends, you'll know how common it is that Nevadans don't get timely refunds of their overpayments or communications from medical providers, and you'll know the necessity of AB 282. Thank you.
David Orient-Licker, thank you, Ellen. I'm sorry you had to go through that, but thank you for trying to help other patients. Okay, I'll now go through the provisions in the bill, and these are based on legislation that's been enacted in Minnesota. Section 2 discusses the obligations of hospitals and other healthcare facilities, while Section 3 discusses analogous obligations for doctors and other healthcare professionals. So same rules, different sections for facilities and professionals. These obligations are triggered when a facility or a practitioner is notified about a potential overcharge or other billing error. If this bill had been passed before Ellen's case, the provider's obligations would have been triggered when it was notified by the insurer how much the provider would be paid and how much of the total payment was Ellen's responsibility. In other cases, a patient might notify the facility or practitioner about a possible billing error. Once on notice, facilities or practitioners would have to do what one would expect them to do, look into the situation to see if there's an error. And they would have 30 days to investigate. Once they complete their investigation, they would have another 30 days to refund any overpayment or explain to the patient why there was no error. As I indicated, healthcare facilities and practitioners already should be doing this. If a patient has concerns about a charge, their healthcare provider should look into it and let the patient know about the results of their investigation. The bill also would preclude the facility or practitioner from billing the patient during the time that they're looking into the issue, and that billing prohibition would apply only to the specific charge in question. The patient still could be billed for all other charges. Note that this billing limitation wouldn't apply in cases like Ellen's, because patients in Ellen's kind of situation pay up front. So there's no new bill, they're just trying to fix the old bill. It's only in the past couple of days that I've heard from stakeholders, so we haven't had time to work fully through their concerns, and we will. No doubt there will be an amendment up to this, but I'll go through a few of their concerns. One is about the range of potential sanctions. Section 1 of the bill includes suspension or revocation of licensure for facilities, with milder sanctions in Section 4. So there's a full range. Concerns have been raised about the possibility of suspension or revocation of licensure in Section 1. But the range of potential penalties actually is in line with existing sanctions for similar violations. These aren't new, these are incorporating what we already have in code. Indeed, the penalties for the conduct addressed in this bill already exist and have existed since 1999, perhaps even earlier. Under our Patient's Bill of Rights, hospitals are subject to suspension or revocation of licensure for failing to recognize patients' rights, including a right to examine the bill for their care and receive an explanation of the bill. For those of you who want to check, that's NRS 449A.1067. I've also heard concerns that this bill would make it too easy for patients to trigger the duty of health facilities or practitioners to investigate. I'm interested in hearing more about this because, as I indicated, the bill seems to state the obvious. When your patient has concerns about a charge, you should look into it. And as I've mentioned, patients already are entitled to receive an explanation of their bill. That said, I will work with the stakeholders to ensure that we get the language right on this question. I've also been asked to revise the kind of information that providers have to include in their response to patients. I'm happy to work with stakeholders on that language. And there are some other things about the time limits for patients to raise concerns. I have in mind Ellen's kind of case. They overcharge, they realize it, they file a complaint. I don't have in mind the 10-year-old bill. How to pay the patient seems reasonable. Instead of setting a check, to apply it to an outstanding balance. Do I mean 30 calendar days, 30 weekdays? Happy to work through all those fine-tune issues. So thank you for the chance to present this bill, and I look forward to your questions.
Thank you. We have a few questions on the docket. We'll start with Assemblymember Jackson.
Thank you, Chair. This is a bill that's going to help all Nevadans regardless of class. Thank you for presenting this bill. I was just curious, is there any data on how many folks that may be impacted by this, or an estimate of how many claims that this happens to?
David Orentlicker, very good question. I don't know, but I'll see if I can find out. Good question.
Thank you. Next, we have Assemblymember Nadim.
Thank you, Madam Chair. Thank you for bringing this forward. So just for my understanding, what happens if the patient is getting billed extra, they paid extra. So they talk to the insurance and the insurance take care of it, and the insurance talk to the provider, and the provider has to return that money. It's legally, morally, ethically. So they have to do that already. It's there. So, I mean, at that point, when you were affected, did you talk to the insurance that this is what happened?
Yes, Ellen Spiegel for the record. Thank you for the question. Yes, I spoke to the insurance company. I spoke to the provider. I sent letters. I filed a dispute with the insurance company because, like most people, at first I actually thought it was the insurance company's fault. And it's really easy to blame the insurance company versus the entity that might have just saved your life. So yeah, I went to everybody, and it wasn't the insurance company. It was, and it gets very technical as we talk about medical billing and things like that. But what happens is, it's not, when they talk about your out-of-pocket maximum, they use a thing called an accumulator where they add up what you've spent. But when they add up the dollars in the accumulator, I actually naively thought it was on the date that you spent the money. And it turns out it's not on the date you spend the money. It's on the date that they finalize your EOB, your explanation of benefits, and then apply that to your account. So you might have spent money up front that, like I spent $10,000, but only $7,000 of it made it into the system. Well, I was supposed to not pay more than $7,000, but you know what I'm saying? It because of time delays. And yeah, I did go back, and like I said, I left no stone unturned. And I sent my insurance company a 19-page fax because they would only take faxes, and I got somebody on the phone and wanted to go through it with them line by line, detailing every single thing.
Thank you. Next, we have Assemblymember Gonzalez.
Thank you so much for your presentation, and thank you so much for this bill. I agree that this is a huge issue. And so my question is, or maybe you can explain, right, in your situation, you paid an amount of money, you knew, right, you were following very closely, right? How does this work in situations where people aren't looking at that, or maybe don't know how to navigate this very convoluted system, shall I say?
Ellen Spiegel for the record. They don't get their money. It's that simple. They don't know that they're owed money. They don't get the money unless their provider sends them a check or issues a credit card refund. At the same time I was going through this, I had a friend who was going through colon cancer. And I said to her, I said, I've put together this spreadsheet where I keep track of everything, and I can share it with you so you can put all of your payments and all of your bills and everything in there, because if this is happening to me, it could be happening to you. And she said to me, I'm going through all this treatment, and I'm going through chemo, and I'm going through this, and I'm going through that, and I just don't have the strength to do it. I don't know how you're doing this, but I don't have the strength, and I'm sure it'll all work out in the end. And she never did it, and I don't know if she's owed money. She doesn't know if she's owed money, but I know we'll hear from some of the folks who are supporting this bill that it really is pretty prevalent.
Thank you so much. So there's nothing in this bill that would help make it so that somebody would know, for example, like you stated, if there was to be a refund and the consumer or the patient didn't ask for it, the insurance company was like, well, I'm going to wait for them to ask, and nobody asks, and then that money doesn't get refunded. Is there some type of mechanism that would help folks?
Your microphone.
Yeah, David Orentlicker. The obligations of the providers can be triggered when a patient like Ellen calls, but it's also triggered once they're notified from any source that they've overpaid. So once the insurer finalizes payment and says, we're going to pay you $500 and we're going to pay the full $500, the patient owes you nothing. Now the provider's on notice. Oops, we already charged that patient $500. That triggers their obligation to refund the money.
Next, we have Vice Chair Nguyen.
Thank you, Chair, and thank you, Dr. O, for bringing this. I think this is very needed in terms of the complexity in terms of medical billing. And, of course, as a patient and as payer myself, even though with a lot of knowledge that I have, sometimes I don't even know what I'm looking at in the EOB. I think EOB needs to have, a degree in it, maybe. But on that side, on page 5, I'm a little bit concerned of the language because, I do have a little knowledge of running a medical facility. So on page 5, on number 3 of the provider of health care violate any provision and then subject to disciplinary action by the board. Speaking from a provider perspective, I know that many of the providers don't even get involved in their billing, right? It could be a staff that handle it. They have a biller in the office, or they have an office manager to handle it. I'm not sure if the language is too harsh in terms of putting it on the provider, because they're focusing on patient care, they're focusing on, making sure that they have those duties, but the billing itself may be on someone else's. So perhaps as we want to, keep the healthcare provider in our state, because we have those shortages, I want to make sure that we're looking at this a little bit more closely.
David Orentlicker, thank you for that concern. I'm reluctant to say doctors shouldn't be, or other providers, responsible for what happens in their office. But I do appreciate, we don't want to be, the goal here is not to be draconian and to slap people, because as I said, a lot of this is inadvertent. The only thing I'm not sure about with the language is how, we have certain ways that in existing code, and if we start changing the way it's written for this particular issue compared to other issues, I don't want to start having all kinds of variations. So, but I want to, this is something that needs to be looked at, and I just want to make sure that I work with legal counsel who knows our style better than I do.
Thank you, and thank you, Chair. And yes, I agree with you. I'm not necessarily wanting to be too punitive, but at the same time, I want to ensure that we cover the entire ecosystem that might be involved with this, even though, yes, they are ultimately responsible for what's going on in their office, but I do believe there are other players in place, and we want to make sure that we address the right issue with the right, error.
David Arntlicker, thank you. That's for the clarification. That we'll make sure that we do that.
Thank you. Next, we have Assemblymember Edgeworth.
Thank you, Chair. Thank you for bringing up this important issue. I have family members who have been through major medical malfunctions and EOBs, even with medical training. This whole EOB thing is a whole, I felt like I needed to get an accounting degree. So I agree with you. And it isn't, and when we say providers, I know we're usually thinking doctors, but it's also physical therapy. It's also occupational therapy. It's many different people are considered providers, and it's all very confusing. Also, when an EOB comes out, it is, a lot of providers feel like the EOB isn't okay, so they dispute that the EOB is accurate and that they felt like they provided a higher level of service. That adds a lot of confusion to it. And also, exactly as somebody mentioned, there are a lot of third parties. So often it isn't even your staff in a busy office. There's a whole third party in another state, accountant, that's trying to be figuring all of this out. So I agree that it adds to the confusion. I do echo Assemblyman Nguyen's concerns about making it harder to be a medical provider in the state of Nevada, because we don't have nearly enough providers, and if you make it harder and harder to be a provider. So I would hope that there would be something somewhere between noticing there's a problem and immediately punishing people. I would hope that there would be some sort of a remediation process where people can hope to correct the problem, rather than just throwing people under a bus. I did have one tiny question. My tiny question is, how do you plan to educate consumers about how to complain? Because the sickest people honestly have no energy for it.
Ellen Spiegel for the record. So first of all, thank you for the question and happy birthday. And as I read through this and I was looking at my own personal experience, the way that I read the bill and the way that I anticipate it would happen is because the big example that I gave, there was a dispute in the EOB. So the provider would have then sent me a notice that said, the EOB is being disputed, so we're taking 30 days because that's the process we have with the insurance company to dispute this with the insurance company. And then I actually got a second EOB that I didn't bring up in my testimony, and that actually had me have a $0 copay because at that point I was officially at my out-of-pocket maximum. And then by the time the third EOB came in for this exact same thing, at that point it was finalized. But then I would have had communications, and they would have said to me, there's a dispute going on between the provider and the insurer, and we can't give you a refund yet because we don't know what the proper amount is. So what this bill says is that once it's finalized, once the EOB is finalized, then you get your refund. And in the meantime, there's just some communication so that the patient isn't just left in the dark.
Thank you for the clarification.
And David Arntlicker, and your concern about making sure, again, that we don't just immediately come down with a hammer. I agree, of course, we need to be take into account. It's a first time, innocent. That's very different from somebody who's a repeated, egregious offender. And if it makes sense to clarify that in the statute, it gets back to what I said before. I'm plugging into our existing system, and maybe we've got a systemic problem that we should address. And so I'm happy to look at that.
Thank you. Members, any other questions? Seeing none, we'll ask you to step back, and at this time we will open up testimony in support of Assembly Bill 282. If you are here in support of this measure, please come forward and fill in the chairs. Anyone in Las Vegas, although I don't see anyone there. You may begin when you're ready. Please state and spell your name for the record. You have 2 minutes.
Good afternoon, Chairperson and committee members. My name is Vivian Leal, L-E-A-L. I have been a multiple sclerosis patient and melanoma survivor for 26 years. Just that sentence tells you something else about me. I am a battle-trained in the dark depths of the healthcare labyrinth in which most patients with serious and chronic illnesses are trapped by a predatory, legislatively enabled system of exploitative prices and intentionally obscure pre-authorization and billing formulas and procedures. I know how to read my EOB. I track what costs are put into one billing pocket or another. I've had to learn billing codes and secret phrases to say to get answers, and I have been lucky to recruit doctors of conscience to provide the extensive documentation required. And yet, I am forced to file an appeal almost every year, often to get the same medication at the same dosage on the same insurance plan. I won this year. As you can see, I can still walk and talk. Most often, I win. Still, there are so many trapdoors, even for me, and especially for the newly diagnosed, those depleted by their illness, or just the plain battle-weary. This bill addresses one of them, the latest pit I have found myself trying to climb out of. Insurance companies often change preferred diagnostic lab providers like LabCorp, Quest. I'm not singling anyone out, but just from year to year. And I have learned to make sure that I go to the in-network one wherever possible. However, despite presenting my insurance cards, my ID, the tests are often built incorrectly or denied due to a missed detail, an error in data entry, or billed into the wrong pocket, or reimbursed at an incorrect rate depending on the particular test and date. Worse, there are overlapping deadlines, which you've heard about, and every correction allows the provider or the insurance company a set amount of time to correct the errors and rebill. Meanwhile, the bills continue to arrive. I am still working on one from January 2024. By the time all the information gets aligned and the claims deadline may have passed, or I run out of stamina and just pay the couple $100 because, frankly, I get too exhausted and beaten down.
Thank you. If you'll begin to wrap, you're over your 2 minutes.
Yes. And that's me, who veteran legislators here may recognize as a seasoned advocate with 2 master's degrees, a support network of friends, doctors, and family who show up for session after session to give you a real sense of what patients endure and how to make it better. But patients should not need an accounting and legal experience to be treated fairly for what is, after all, healthcare we already pay for at extortionary prices. AB 282 would eliminate just one of the hazards we face in starting to stay healthy, functional, and darn it, just saying.
I appreciate your comments. If you don't mind, you're welcome to leave your written comments with our secretaries. We'll be happy to add them to the record.
They're in your file. It's a lot to say in 2 minutes.
I know it is.
25 years of experience in this.
We appreciate you. Thank you for being here. Go ahead.
Good afternoon, Chair Brown May and the committee. Thank you for allowing me to speak. My name is Jane Grossman, Jane Grossman. I urge you to support this bill, AB 282. Most Nevadans sadly will need to wrestle with our healthcare system over the course of their lifetime. My first match was trying to get insurance in 2006 before the Affordable Care Act because I was denied. I did finally get insurance, but it took some time. My latest battle came in 2023 when I was diagnosed with high blood pressure, a trigger thumb, hypertrophic cardiomyopathy, dural arteriovenous fistula, obstructed sleep apnea, and allergies to prednisone, which showed up after I had a rash from my CPAP. To say the least, 2023 was not a good year. Dealing with these medical issues entailed visits to 74 different doctors, not different doctors, but different appointments, and going out of network seeking second opinions. My bills totaled $195,136. Thankfully, my out-of-pocket max was $7,000. Thankfully, I know how to use spreadsheets, and as everybody has talked about, there's green like that matched, and yellow and orange and red, trying to figure out all of these charges. With all of those charges, as you could imagine, I was overbilled. I did have to go to the MAT to get about $1,000 back. One bill for $800 took me 8 months to go back, and this was many phone calls, many emails, in-person visits, and more. And this was a charge that I did have to pay at the time of service. So I believe AB 282 is very needed. It will help Nevadans like me to get a fair deal with our healthcare system. Thank you so much.
Thank you. Is there anyone else here in support of Assembly Bill 282? Seeing no movement here and no one in Las Vegas. AVH, is there anyone on the telephone lines in support of AB 282?
Public line is open and working. There are no callers at this time.
Thank you, AVH. At this time, we'll move into opposition. Is there anyone here in opposition for Assembly Bill 282? Please come forward. You may begin when you are ready. You have 2 minutes. Please state and spell your name for the record.
Good afternoon, Chair Brown-May, members of the committee. For the record, my name is Nick Schneider, Schneider. I'm the Director of Government Affairs for the Vegas Chamber. We appreciate the intent of this bill. However, the Vegas Chamber is in opposition to AB 282 on a number of technical aspects. We do have some concerns regarding there being a hard deadline for response to a medical billing error. However, this bill does not provide a statute of limitations for the patient to file this notice. Nevada currently only requires doctors and hospitals to maintain records for 5 years. A complaint for an outstanding invoice that has lapsed beyond this could result in significant delays in providing that review. Further, we believe the penalties outlined in Section 1 to be just a small step on the egregious side that could disincentivize doctors from coming to Nevada to practice, particularly with the phrasing in Section 2 that could have a clerical error impact the license of a doctor who provided treatment. This issue is compounded by the language in Section 3, Sub 3 that presumes guilt of unprofessional conduct. I would like to just quickly thank the bill sponsor for meeting with me this morning. We look forward to working with him on these concerns, and thank you for your time.
Good afternoon. My name is Patrick Kelly, Kelly. I'm with the Nevada Hospital Association. We oppose the bill as written currently. This bill just dropped a couple days ago, and we haven't had time to really go through it, but the sponsor's been great in reaching out to meet with us, and we're going to continue to have discussions with them, and I think we'll get to a good place. So thank you.
Thank you. Oh, sorry, go ahead.
Thank you, Chair and members of the committee. Blaine Osborne, Nevada Rural Hospital Partners, for the record, here in respectful opposition to the bill as it is currently written. We, too, are among the stakeholders who haven't had a chance to meet with the proponents yet, so my apologies to Assemblyman Orentlicker. We will continue this conversation and try to fine-tune the language to get to a place where we can be in support. Thank you.
Thank you. Is there anyone else here in opposition? Seeing none and seeing no one in Las Vegas. AVH, is there anyone on the telephone lines in opposition of AB 282?
Public line is open and working. There are no callers at this time.
Thank you, AVH. At this time, we'll move into neutral testimony. Is there anyone here offering testimony in neutral for Assembly Bill 282? Seeing no movement here and no one in Las Vegas. AVH, one more time. Is there anyone on the telephone lines in neutral for this measure?
The public line is open and working, and there are no callers at this time.
Thank you. At this time, we'll invite the bill sponsor back up for closing comments.
David Orentlicker, thank you for hearing the bill. Thank you to my predecessor for coming back and continuing to try to improve things in Nevada. And as I indicate, I'll be working with the stakeholders, and please follow up with me for any questions you have. Thank you.
Thank you. At this time, we'll close the bill hearing for Assembly Bill 282. That brings us to our last order of business, where we will move into public comment. Anyone wishing to offer public comment is welcome to come forward in Carson City at this time. If you'd like to call online, you may dial 888-475-4499, and then when prompted, enter the meeting ID number 876-3267-8981, and then press the pound sign. when prompted. Seeing no one here wanting to offer public comment at this time, and no one in Las Vegas. AVH, is there anyone on the telephone lines?
Public line is open and working. There are no callers to provide public comment at this time.
Thank you, AVH. Members, that concludes our business for today. We do not have a meeting scheduled for Friday, so we will look forward to coming back into a scheduled meeting on Monday. Please check your agendas for the scheduled bills. This meeting is adjourned.